diseases. I now request Dr. Vishali Gupta for her talk on infective retinal and choroidal disorders.
Thank you very much, AIOS, for the kind invite. Over the next few minutes, I'll be talking about a simplified approach to posterior uveitis. So whenever we see posterior uveitis, essentially what you see is some kind of yellow lesion out there in the fundus. And there are two very important steps which you need to know. The first is, what is the location of that lesion? Is it involving the retina or the choroid? And primarily in real life, we do not have pure retinitis or pure choroiditis. It can be either retinochoroiditis, which means retina is the primary site, or it could be chorioretinitis. And lastly, you could have the inflammation of retinal vessels called vasculitis. The second step which you get confused is now what to order. Please remember, there is absolutely no role of serology in posterior uveitis except for syphilis and HIV. Rest of no serologies have any role to play. Imaging has come up in a very big way, and it does help us in recognizing the etiologies. Radiology in select cases, and of course the biopsies in very extreme and difficult cases. Now, what do we do when we are encountered with a patient who has I would say, a yellow lesion in the fundus? As I mentioned, first look at the lesion clinically and try to determine, is it choroiditis or retinitis? How? I'm going to show you over a couple of slides. If it is retinitis or choroiditis, is it just a focal lesion or is it diffuse? Then you come back and see, is there any associated inflammation in the vitreous anterior segment? Look at the patient as a whole. Is the disease confined only to the eye, or are there any systemic diseases? And then you order the imaging. Don't believe in that multimodal imaging simply because you hear it in the meetings. It has, it's fancy, but you should be mature enough to do customized imaging, what your patient needs and what information you want. And if the patient has a disease which is healing in the opposite eye, pay attention, because the healing pattern itself might give you a lot of clues. Investigations, I already said, serology no role, imaging customized. Radiology, if we are looking at some systemic focus, and biopsy in extreme cases. Now let's come to the actual clinic. So this is the stepwise approach, what it is. Now you look at the yellow lesion, which is fluffy, which has the borders that are not discrete. You can't see retinal vessels on top of it, that's retinitis. And these days we have OCT, which very beautifully shows that it is the involvement of the retina or the choroid. Now let's look at this lesion here, which is a very typically how a retinitis lesion would look. When you look at retinitis, to me, there are only two differentials, toxo or Behçet's. I won't even go into neuroretinitis or lymphoma because that's not very common. So is it toxo or is it Behçet's? Look at the overall fundus. Are there multiple small patches of retinitis? That's more like Behçet's with capillary involvement and of course the fluorescein. But toxo is classically what you show. The textbook will tell you that it is next to a scar, a congenital scar, which is not the real world. Those are the old textbooks. The real world is it can be acquired, and you could just see one patch of retinitis, headlight in the fog if you see, very good. But even if you don't see, it's not that it's not toxo. So single patch of focal retinitis, toxo will be highest, followed by Behçet's. On this side is the diffuse retinitis. You can see it's retinitis, it's yellow, it's diffuse, it's in the periphery and it is diffuse. Now, this is something which you cannot afford to miss because this is very classically viral. You do not need any investigations to diagnose acute retinal necrosis, progressive outer CMV. These are very classical book pictures. Please start the treatment. Even if you are in doubt, do not wait for your Monteus and God knows what all reports to come back before giving antiviral. Just start it. Believe in yourself. And then rarely we do have infections like syphilis, toxo, which could mimic, but I will not go there. Now you have seen the patient clinically. What would be the next step? The next step would be multimodal images and tailored investigations. So when you are doing imaging, or even the labs, you should ask yourself a question. What am I going to get out of that imaging? And when the result comes, either it is a lab or it is an image, how it is going to influence my decision. Just don't do things because you heard XYZ showing beautiful images from a latest camera. That doesn't work that ways. So multimodal imaging, you want to know what is the site of involvement, and there are very specific imaging biomarkers that can tell you whether you are dealing with infection or not. Lab investigations are very minimalist and tailored, and let's go to example how you do. This is a case you are seeing. There is a retinitis, and I think it's clear, and you also have a retinitis next to a scar which you can see through the haze, and this is classically what you call headlight in fog. So you know it is focal retinitis. And from your knowledge, you also know that if it is next to the scar, it's most likely to be toxo. So TB or syphilis or other things are not even in my radar. So why would I investigate this patient for TB, then want to come positive, then start ATT, and then getting confused all over? So just ask yourself a couple of questions. Is it chorioretinitis or retinochoroiditis? Well, it is retinochoroiditis. It's headlight and fog. It is unilateral. It is focal, overlying vitreous. Cells are present, and we are seeing a satellite lesion next to the scar. So what is the clinical impression? Toxoplasmosis. Is there any differential? No, there is none. So what will you do? Clinical phenotype is the strongest. Would you do serology? Probably not. We used to do toxoserology long time ago. Nowadays, it has absolutely no role. MMI, yes, you can look for OCT biomarkers, and other things do not have a role. Now, what are the OCT biomarkers which will show that it is probably a toxoetiology? In a clear media, through the lesion of retinitis, if you see these oval deposits on the inner retinal surface, if you see these round deposits on the posterior hyaloid and these mirror images, hyaloid and retinal surface, these are the ones which are very classical for toxoplasmosis. And as you see here, this is the involvement of the retina, and toxo invariably involves choroid along with it, retinochoroiditis. So on OCT, you see retina and choroid both involved. If you are confused between toxo and viral majority of the time will not have the underlying choroidal involvement. And that's a very important clinical clue towards what you are dealing with. The second example which I said, it could be multifocal retinitis. As you see, these lesions appear a bit different than what we saw in toxo, but we do know they are retinitis. So retinitis, bilateral, multifocal, very few vitreous cells, and there is history of oral ulcers, arthalgia. So this goes into Behçet's. I will not confuse it with toxo. So what do? You do the fluorescein angiogram, You see the leakage from the capillaries, which is very typical fern-like leakage. You do not need any other lab. HLA typing B51 maybe, but not really. So it is only the history and the fluorescein which is required to make a diagnosis of Behçet's disease. And this is very typically Behçet's angiogram. You see fern-like leak, which is leaking in the late phase. If you pay attention, these are the capillaries which are leaking and not the major vessels. This is generally bilateral. When we come to diffuse retinitis, as I already said, diffuse retinitis is more of a viral etiology, and you cannot afford to miss that. When you see diffuse retinitis in a clear media, granular appearance, intraretinal hemorrhages, this is more like CMV, the classical Pidzon pie appearance or brush fire or whatever, but this is like you see and you say, well, it is CMV, let's treat for CMV. Very rarely, diffuse retinitis, scarred next to it in the posterior pole. Now, these kind of situation happens when people give steroids without understanding. Now, this is a patient. It does not classically fit into ARN. It does not classically fit into toxo, and it also does not classically fit into CMV. It could be any one of these. So, if you want to differentiate, sometimes the OCT does help, as I indicated earlier. Toxo will have underlying choroidal involvement. Viral will have retinitis, but no underlying involvement of the choroid. So after the retinitis, we move briefly towards choroiditis. And what is the choroiditis? Choroiditis is actually a very close call between infective and non-infective. And again, the pattern recognition is extremely important. When you look at the choroid, it could be diffuse, it could be multifocal. If it is diffuse, again look, is it primarily retina involved? Then you go in the direction of what I have shown already, toxo or viral. But if it only choroid involved, then it is serpiginous choroiditis. Serpiginous choroiditis traditionally is autoimmune in nature, which is bilateral, no inflammation, lesions in the juxtapapillary area, not multifocal. What we see in our country majority is serpiginous-like choroiditis, which tends to be infective, mostly immune response to tuberculosis, which is unilateral, associated inflammation in the vitreous. Lesions may begin in the posterior pole, multifocal, and there may be associated vasculitis. And then there are multifocal choroiditis, which is mostly white dots, and we have very recently abandoned the use of white dot syndrome, and we have a session a day after tomorrow by IOSG that this term is a waste box and should not be used. Now, sometimes when you see these choroidal lesions, you have to pay attention to what you are seeing even in the imaging. I will show you 3 examples. When you look at it, this is something called APM-PP, which is idiopathic. When you look at the angiogram in APM-PP is hypo, uniform hyper. This one is serpiginous-like choroiditis. The angiogram has an edge because it's growing in a serpentine fashion. So you have an edge which is becoming from hypo to hyper. And this is syphilis, which produces a classic ground glass appearance on angiography. So this appearance of syphilis, the ground glass appearance which you see, haze in the late phase, always rule out syphilis. So I was talking about this patient in the beginning, that this is actually a young girl. She has received intravitreal triamcinolone, oral corticosteroids, and even TB drugs. And she was not responding. The vision is counting fingers. So what is it? Is it retinochoroiditis, vitritis, or this? So it is very important to look at the past episode. So when we look at the past episode, this is the way patient had presented to the physician, the first treating physician. I mean, it was toxo written on the face, on the retina. You did not need to do Monteus and ATTs and steroids and triamcinolones and all, you know. And this is where he ended up the patient with. We did the vitrectomy and all, and of course there were toxocysts. That's besides the point. The point is the patient still lost the vision because somebody just missed the very basic, simple diagnosis, which was just there, you know, it was just obvious. So another serpiginous and serpiginous like this is classic serpiginous. We do not see much in our country, which has the pseudopodia-like projection starting from the optic nerve head, and there is a progression. This little bit white that you are seeing, this is what it progresses, and this is how it heals. What we see is like this: multifocal patches, here, yellow, vitreous cells, inflammation, some vasculitis. This is tubercular serpiginous-like choroiditis. So this is very different from the classical serpiginous choroiditis. And you need to be able to differentiate the two. I already told the differences, but we've published them very well. Nutshell, if you see multifocality as well as the vitreous cells, it's more likely to be TB, so don't push too much immunosuppression. So this is my last slide of choroiditis. If it is diffuse, it can be toxo or viral, serpiginous. You need to differentiate. If it is a very classic autoimmune variety, which I said generally we don't see, you may not treat, may give steroids, but if the patient is not responding, you may investigate. But if it has inflammation, the chances of TB is very high, so you always investigate to rule out infectious etiology. Multifocal choroiditis, there are some classic phenotypes, PIC, MUDES, AMPI. We haven't discussed all those, but generally they are very classy, and we do have a symposium on 4th. If you want to learn, you could come. You do not need to investigate. However, anytime either the patient is not responding to the therapy the way you wanted the patient to be, or the presentation is atypical, always investigate to rule out whatever you think are the possible etiologies. But please do not investigate every patient for everything. Thank you very much once again.